into a newborn day. Oh, flaming with all the glow of sunrise of beams, time is calling the vow that all betray. For the passions that thrill love and lift you high to heaven are the passions that kill love and let you fall to hell. So exit stories softly as in an evening sunset. The light of big glory will take it all away.
Welcome. It's great to see such a fine turnout to celebrate the 25th anniversary of what used to be called the Human Life Research Institute of Ontario. Our mission has been to carry out objective, scientifically impeccable research on bioethical issues, everything ranging from pain control in terminal care to the use and abuse of drugs, to infanticide, to euthanasia, to abortion. We're very pleased to have you here, and I just want to say a word of introduction for our keynote speaker tonight, Dr. Deborah Zeni, who's a family practitioner in Georgetown with a specialty in obstetrics. She's also a pediatric consultant, and she has been honored in various ways. In 2005, the College of Physicians and Surgeons for Ontario gave her its coveted award for excellence in community care. She was the one person selected from all the physicians in Ontario for this award. In 2006, she and her husband Paul, who's also a physician, received the Undergraduate Preceptor Award under the Royal Ontario Medical Program. That's for medical teaching. And tonight, she's going to speak to us on young women at risk, abortion, and consent. So, Debbie, here she is.
Welcome. This is a wonderful turnout, and I'm really thrilled to see so many people come out. Many of you don't realize that Barry deVeber, who the Institute is named after, was actually my mentor and professor of pediatrics when I was doing my pediatric residency program in London about 26 years ago, about the time that this institute was first founded. So we've had a long and cordial and, for me, extraordinarily beneficial relationship. And I thank Barry for all you've given to so many people. I was delighted to see some familiar faces. I hated to admit that I missed some of you when you sort of came up to me till you were close, but I left my glasses in the car, so I couldn't see you. I'm also glad to see so many young people and new faces out here. It is rather wonderful that people are interested enough in the issues facing young women that you will give up a night and come here and listen to me talk. For myself, I will admit that I'm not only a bit surprised to be here, but I'm rather horrified that I actually am here, because there are many, many other people in this audience who are much better qualified to give this talk than I am. And I'm not a lawyer, I'm not a gynecologist, I'm not a bioethics expert, I'm not a philosopher, but we're going to be touching on all those subjects this evening, and I hope that from this perspective of the fact that of the young woman who faces the issues of induced abortion, that I will make some sense of it for you, and that you will also enjoy the evening. And I must say, it was a very, very enjoyable beginning. The band was great. Can we give them a bit of a hand? It's from the perspective of my concern for young women, or women, mothers and children of all ages, that I come to you here to advocate for them and to put the face of suffering which induced abortion carries with it in some cases. Put a face on that for you. But first, I'm going to give you a few of the facts so that you have a place to put everything in a big picture. Last year in Canada, we had about 352,000 babies born. And for that number of live births, we also had an abortion rate of about 100,000 abortions done in the last year in Canada. That gives us an abortion rate in Canada of 30 abortions for every 100 live births. And if you actually look at the statistics over the years, one of the things which you will see, and which bothers a number of people, is that the actual birth rate is declining in Canada. And that's a concern. Most of the abortions done in Canada are done in the first trimester, between 9 to 12 weeks, about 75% of them. The large majority of abortions are done on women between the ages of 15 and 30, with the bulk being done between the ages of 20 and 24. And it actually is a nice bell curve when you look at it. Of the women who get abortions, about 30% of them have a repeat abortion, and there are a small distal tail of women who have multiple abortions over 5. Tired of the stats? We can shift gears and put a human face on it. For it's that face of frustration and hurt and pain, lack of understanding, that motivates me to be up here tonight. Believe me, nothing much else would do it. Okay. A few weeks ago, I was called into Emerge. I cover pediatric on-call for Georgetown Hospital. Oh, and just by the way, that community award from the College of Physicians and Surgeons, I won that with my husband, Paul. I could not do it on my own. Okay, so I was called into Emerge a couple of evenings ago, and that's a regular occurrence. And as I was making my way from the parking lot to the Emerge doors, I was almost accosted by this lady who was trying to help her daughter to emerge. And I looked at the young lady. She was about 19, 20, and she looked pale and sweaty, really unwell. So I ran for a wheelchair because I didn't relish the idea of carrying her through the parking lot into the Emerge myself. Got the wheelchair, plunked her into it, and we took her to triage. And it wasn't until an hour or so later, after I had stabilized the child, had gone in to see, that I walked past her room. The young lady had an IV running, and in it there was blood being transfused, and she had her antibiotics running. And her mom was there, and I realized that her mom was one of my patients. I didn't have my glasses on that night either. And just in the rush of everything, I hadn't quite realized who these people were. So Carly's mom came out of the room and said, "Dr. Debbie, I really need to talk to you." And I said, sure, I'll stop talk to you. And apparently Carly had been into Toronto about a week and a half prior to that and had had an induced abortion. Mom wasn't sure how far along she was, but it sounded like she was about 10 weeks along. And then Mom just rushed into the whole story. She kept on telling me that they were really so sorry that all of this had happened. That if Carly had at least confided in them, that maybe something different could have happened. And that they were really surprised that Carly got sick, because the people at the clinic had told her that she wouldn't get sick. And every time her mother said, "You need to go to a doctor because you're not feeling well," she kept on saying, "No, they told me I wasn't going to feel quite right. No, this is fine." And the truth is that the people at the clinic had told Carly very, very little. And certainly hadn't told her what she needed to expect or what she needed to do with respect to making sure she got the appropriate medical care if she got into complications or into trouble. And Mom went on. "You know what? Carly was just so afraid. I think she just went in there and she just blanked out everything which they said. I really don't know what to do. I really don't know what to think. It's just really quite horrible for us. we're just so glad we didn't go up to the cottage, because then she would have been sick at home, because, you know, the boyfriend hasn't been around. He hasn't been around ever since. And, you know, he was the one who talked Carly into doing this. We wouldn't let her do it. And I don't think when somebody's 20, you can say, I'm not going to let them do it. I've got a 20-year-old at home. I find it really difficult to tell my youngest one, you're not going to do that. I tried the other night. I didn't get very far. So, but Mom's sentiment was genuine. She was validly concerned about her daughter's well-being and really, really quite worried about how she was going to be. And that was shown by the next set of questions. She said, is Carly going to be all right? What happened? Why is she here? Why is she like this? What is going on? Can you tell me that she's going to be fine? Will she be okay? And at that point, I stopped looking around for a nurse to rescue me, because I knew that this mother needed some sort of medical care and attention herself. She needed somebody to say, listen, take a breath. The best thing you can do in medicine is to take one step at a time. You know, she's stable now. She's going to go to the OR. Afterwards, she's going to get better. You see me in my office and follow up, and we'll discuss the rest of it when we get there. Mom nodded and accepted that. And then, just as she turned to go back into the room, she said, I guess Carly should have taken the antibiotics that she was prescribed. And I agreed, and was hauled off by a nurse to see another child. Carly, the sad part about this case is that Carly is not an exception. The fact that she ended up with an aseptic abortion done in an accredited clinic in Toronto under sterile technique is not unusual. The fact that she ended up with post-abortive bleeding is not unusual. If you look at the rates of immediate complications across the world in developed countries, they range anywhere from 5% in Denmark, and I really haven't quite figured out what Denmark is doing so well to have a complication rate that low, all the way up to 17% in the United States. That means that if you're doing 100,000 abortions a year, as we do in Canada, 10% of those women end up with immediate complications of their pregnancy. They end up needing to see a physician, either in a walk-in clinic or in an office, or going to emerge to have their problems treated, their problems which are directly attributable to their abortion. To put this into a bit of perspective, I'm again going to give you a few stats. People say stats can lie. They can't. But stats can also give you a perspective. Abortions are a simple procedure which are done on an outpatient basis under what we call awake sedation. Have you ever heard such an oxymoron in your life? Awake sedation. Anyways, that's the medical term for being sort of awake and sort of asleep while you're having your procedure done. So there isn't the complication of having a general anesthetic. If you look at other procedures which are done in our hospitals under the same conditions with the same anesthesia, such as an inguinal hernia repair, anybody in here had an inguinal hernia repair? Oh, I see one back there. Anybody else? There, and there's another one. The complication rate with that is 1.2%. Now, the orthopedic surgeons get the Golden Scalpel Award because their complication rate for their procedures, which they do under awake sedations like arthroscopies, is 0.12%. Really good, eh? Abortions, induced abortions, 10% in Canada. That's a phenomenal complication rate. That's a phenomenal rate that nobody looks at, nobody talks about, and nobody tells the women who are seeking induced abortions. We classify complications in the medical world under a couple of under immediate or early and late. Some people say immediate's within a week, some people say it's within 24 hours, but in the literature, it's usually taken as up to 3 months, okay? Late complications are those complications which appear months to years later, but most studies which are done on late complications only take into account complications occurring within a year of the procedure. The reason why you need to know that is just keep that in the back of your mind as we look at the literature And we look at both the immediate and late complications of induced abortions. The two most significant immediate complications are the two that I talked about, hemorrhage and infection. And these occur because sometimes a little bit of placenta is left behind, because sometimes there's a tear when the suction curettage does the procedure, and that's why the bleeding occurs. Sometimes the uterus just doesn't contract down because it was a little bit too bulky to start out with, and it just doesn't know that it's supposed to contract down, so it keeps on bleeding. Infection is another problem. The infection rate following induced abortions is directly related to the background rate of STDs in the community. Okay, which is another sort of verboten topic, as we've seen when people have debated whether or not we give Gardasil to young women, which is also a vaccine to protect against an STD, which is called human papillomavirus. So the viruses, we don't know what role they have to play in induced abortions and infection afterwards. But we do know that the organisms like mycoplasmas and chlamydia, and of course gonorrhea, which is not nearly as common, have a pivotal role in infection following abortion. If you have chlamydia when you seek your abortion and it's not treated, your risk of being infected with that is somewhere between 60 and 75%. So what's happened since the 1990s, when that was first appreciated, when our infection rates used to be very, very high, is that now routinely the girls are given, the young women, the women are given a script to go out and buy some antibiotic. And they're hopefully told how to take it. What didn't happen in Carly's case is she wasn't told why. And so Carly said, I don't have an infection, I feel fine, the only thing I have is a pregnancy I don't want. I don't need to take an antibiotic, I'm not sick. So she didn't fill the prescription. She hadn't been screened for chlamydia, she didn't know that she had it, and she ended up with that 60 to 75% risk of becoming septic after her induced abortion. If you treat this, then you can reduce the infection rate down to about 8%, which is good. But it does have a long-term effect, which I'm going to talk about in a minute. These short-term complication rates were picked up in a study which is done by the Canadian Physicians and Surgeons of Ontario in 2000 and 2001. And basically, at that point, because of the change in our technology and because of the change in our anesthetics, more and more surgery has moved to an outpatient basis. And because there's a real crunch on beds, and hospitals don't get the budgets they need to run, hospitals were looking at offloading some of their routine work into clinics. And so the CPSO decided that they were going to study what happened in clinic situations. And the most frequent procedure, which is done in the clinic or an outpatient setting, is an induced abortion. So they studied induced abortions across Ontario. And what they found really floored them. And they published it, but they didn't publish it in the Canadian journals. They published it in an American journal, and a not very well-known American journal. So, but we found the study anyways, and it was really telling. And what they found out that over the baseline population, if they case controlled the women for other women, same age, same area of living, using OHIP cards, okay, they found that there was a 4-fold increase in admission rates to hospital after induced abortions for women for the treatment of medical problems. And the vast majority of these were infections. They found a 5-fold increase over the baseline rate for surgical problems. And this represents the women who are bleeding after they have their induced abortion and they go back to the OR. And they found a 5-fold increase in hospital admissions for psychiatric problems over the baseline of the population. And I don't know how many of you know about how hard it is to get a psychiatric bed, but even back in 2001 with the hospital bed crunch on, you didn't get a hospital bed if you were feeling sad, depressed, upset, anxious, or irritable. You only got it if you were going to commit suicide or if you were homicidal. And there was a 5-fold increase in women who'd had an induced abortion. It tells us that even at an immediate level, there's a significant increase in the rate of mental illness of those women who have induced abortions. These numbers from CPSO only represent the women who were sick enough to need admission. They don't represent the hundreds and hundreds of women who needed care in walk-in clinics. So Carly's mom's comment that surely the clinic should have told Carly what was going on. Surely, why did they tell us this was simple and safe? Her questions were totally valid. Because induced abortions in Canada are neither simple nor safe. When Carly came back for a follow-up visit, we had a brief talk about the antibiotics. That's how I found out why she hadn't taken them. And I said, well, Carly, what sort of things did they actually tell you at the abortion clinic before you had your abortion? She said, well, the counselor handed me a list. And there were a whole lot of words on it that I didn't recognize. So I said, well, I don't really know what all this means. And the nurse told me, well, it really doesn't matter what it means. What you have to do is sign it. So I signed it. What she signed was her informed consent for surgery. Carly told me that, you know, like she didn't really feel that she could ask a whole lot of questions. And she had started asking some questions, and she was really told that, did you want an abortion? And that's exactly what it was for. Did you want an abortion? Is that what you're here for? Well, you know, that's what we're going to provide for you. And maybe this was colored by Carly's experience in the hospital after she had her abortion, but there must have been a grain of truth in what she was telling me, because she didn't have any reason to make it up and say that to me otherwise. So what happened, because Carly wasn't told what the consequences of an induced abortion was, that Carly wasn't informed, is that Carly didn't really buy into what was going to go on. And one of the things which we know is that if you have an informed consent, where a patient really knows what's going to go on and what the results are going to be and what could go wrong and why it would go wrong, their compliance rate is a lot higher. And compliance rate means that you do what you're told to do. What your mom wants you to do, remember? When you did what your mom wanted you to do, you were being compliant, okay? When you, as a husband, say, yes, dear, you're being compliant, okay? And what we want patients to do is be compliant and actually do what we ask them to do. But you can't get that buy-in if you don't tell them what you're going to do. And this is where there's a big breakdown in communication when it comes to induced abortions. And that's only about the immediate concerns. So Carly's mom was in there and she was on this again. Is Carly going to be all right? What about down the road in the future? Is Carly going to have any consequences of this induced abortion when she goes and gets married and she wants to have a family? And at that point, I really wished the phone would ring. Because it's really difficult to sit there and give a mom of a child who had an induced abortion the information that I'm going to give you right now. Because it's not pretty and it's not good. And when we talked a little later, a number of months later, Carly's mom said, you know, I've talked to Carly since then. They really didn't tell her any of the things that you told us. So what about the long-term complication rates? What is it? Well, long-term complication rates are difficult to find. First of all, abortion wasn't, quote, quote, legalized in Canada until the mid-60s, 63 to be precise. And then you had to go to a special board, and your application had to go in front of a board, and it was passed. And in 1988, the Supreme Court said that our abortion law was unconstitutional, and they struck it down. So we don't have an abortion law in Canada, which means you don't have a legal right to an abortion. An abortion is just one of those other medical procedures which you can access because the government pays you to be able to have the procedure. And because it wasn't until 1988 that it was accessible in that sort of basis, there were not a lot of studies done, and a lot of the studies were very small. And by about 1995, the rate of publishing on induced abortions in terms of complications and long-term outlook for people started to come to the fore. And around 95 and 96, there were articles which started saying induced abortions have a significant impact on a woman's future fertility. They have a significant impact on her subsequent pregnancies. And initially, there was a lot of controversy about this. The gynecologists would all tell you, oh, we know. And so when we have a patient in who's had an induced abortion, we always watch them a little bit more carefully, which is legitimate, and that's exactly what they should do. But does the general public know? Are you being told? Since then, in 1995, because there was a fair bit of controversy when these studies first got published, a couple of enterprising people, particularly in Europe, where they do absolutely the most marvelous stats on all their patients, and everything gets recorded. There's nothing that you can get done in France or Germany or anything else like that that doesn't get recorded in some sort of database. That they did two very large studies. One was called the Europop study, and the other one was called the EpiPage study. And they started these studies in 1990, and then in 2004 and 2005, they came out with their final findings. And what they said is that there's a significant increase in the risk of women who have had induced abortions of having problems with their subsequent pregnancies. And Ream in 2004 said that for teenage girls who have even one induced abortion, they increase their risk of having a subsequent miscarriage or a preterm infant by 3 to 4-fold. That's 300 to 400%. That study was buried, and then Europop came along and they said, the risk of having one induced abortion across the board at any age increases your risk of having an extremely premature baby by 30%. Well, you know what? That doesn't sound like very much, does it? But you just think about this. You've seen the anti-smoking advertisements for pregnant women? One induced abortion puts a woman at the same risk as smoking 2 packs of cigarettes a day. Okay? One induced abortion puts a woman at the same risk as being underweight and anorexic when she starts her pregnancy. We don't tell these girls this at all. And what's the risk of? The risk is of delivering a very low birth weight baby. Okay, these babies are generally of a gestational age of less than 31 weeks. You're pregnant for 40 weeks. So these babies are only about 7 months long. And actually, when you work in the nursery like I got to do with Dr. deVeber, you can hold these mitts in your hand. You really can, because they're tiny, okay? They're not fully developed in any which way. They have problems with their lungs, and they have problems maintaining their circulation, and they get problems with their digestion. When I was up in London in 1980, I got to witness the very, very first time we ever shoved surfactant down a baby's lungs. Well, the baby turned black and blue and spluttered and coughed, and then started to breathe. And we witnessed a miracle, and it was wonderful. We have mastered the art 25 years later. We can replace the surfactant in babies' lungs, and we get them to breathe even when they're only 25 weeks of age. But what we haven't been able to do is decrease the rate that they get sick at, the rate that they get complications, and the rate that they die at. They don't die of lung disease any longer, but they still die. 25% of them still die, despite our best efforts. 25% of them still bleed into their brains, or get what we call PVL, which is paraventricular leukomalacia. You don't have to remember that, but it basically means cystic degeneration of the thinking part of your brain. And we have to look at that and say, why is this happening? And then on top of them, despite our good care with the children's lungs, a significant portion of them, 20 to 30% of them, go on and have chronic lung problems. And at the age of 1, it's been like they've been smoking cigarettes for the last 30 years. They have basically chronic obstructive lung disease at the age of 1. And why is this? Well, a lot of people have been asking this question. In 1998, one of the first seminal publications came out, and one of the guys said, I really think it's the chlamydia. And everybody looked at him and rolled his eyes. At that point, chlamydia was getting blamed for absolutely everything. Okay, from stomach ulcers to heart disease, okay? So when this guy came out and said, well, I think the reason why these babies which are born prematurely do so poorly is because they're getting infected with chlamydia and mycoplasms, there was a lot of skepticism. However, now we're 10 years later, cultures have been done, stains have been done, the biopsies have been done, the pathology studies have been done, and it's clearly established that these babies who are born at very low birth weights, spontaneously or following rupture of membranes, a lot of them, almost all of them, have markers of having infections with chlamydia and mycoplasm, the same sort of organisms which are introduced when people have induced abortions, the same sort of organisms which are transmitted as STDs in our population of young people who are practicing what I call serial monogamy. Okay? That means you have one partner after another. So you are monogamous, but you just do it one after another. Okay, the old-fashioned terminology for that used to be promiscuity, but that's really, really, really passé. Okay. Anyways, with this problem of chlamydia, now the research is saying, well, what can we do about it? Is there some way that we can treat these women? Is there some way we can identify these women so we can treat these women before they deliver prematurely? And the answer is not yet. Not yet. But do we tell the women who are seeking induced abortions that this is a problem? Do we tell them that they're at risk of this? We tell them that they're at risk if they smoke. We tell them that they got to eat properly. But we don't tell them that if they go for an induced abortion, they could have a little baby with brain damage, or with lung damage, or with learning disability, or a little baby who might die. Because we don't have informed consent when it comes to induced abortion. So what else don't we tell them? We don't tell them that they also can have other problems such as ectopic pregnancies, where the pregnancy ends up in the tube. That's related to infection as well. Increased rate of miscarriages, as I mentioned before, an increased rate of stillbirths. Stillbirth is a devastating experience for anybody who goes through it. And believe me, every woman who has a stillbirth, that's when a baby dies before it's born, spends a lot of time saying, why did this happen? What could I have done differently? The devastation that happens if the women find out that one of the risk factors was an induced abortion, and she thinks back and said, oh yeah, I had one of those, is immense. The guilt and the grief is great. We have a duty as physicians to let people make a choice before they have an induced abortion. To let people say, to say, that's a risk. We don't know whether it's going to happen to you or not. It's a small risk, but it's a significant risk, and it's there. We should be able to tell these women this. We should be telling the parents. And it's my thought, as a mother of 4 young men, that we should be informing people like you guys, because it's known that 30% of girls who go for abortions because their boyfriends say, I would really think it'd be a good idea. I really am not ready to be a dad yet. So we have this problem of very low birth weight babies. We have this problem of ectopic pregnancies and stillbirths. Do we have any other problems? Yes. One of the most significant problems that we also run into, which is a real taboo, is the risk of having mental illness following an induced abortion. When the early reports of increased mental illness, post-abortion stress disorder came out, there was a lot of flack in the press, and they said, don't you realize that women who go for induced abortions are stressed already, and it's obvious that they're going to be stressed afterwards too? And that's not what the people in the abortion clinics will tell you. The people in the abortion clinics will say, after you have your abortion, you'll have a great sense of relief. And some women do. If you look at the studies, 40 to 50% of women, after they have an abortion, will say, I was relieved, I was happy, I did it, I made the right decision. That leaves the other 50% though. And the other 50% struggle. And out of that other 50% who struggle, there's another subgroup of them, of about 20 to 25% who really struggle. And so what we end up seeing is an increase in suicidal ideation, an increase in depression, an increase in alcohol abuse, increase in drug abuse, and an increase in something which is being labeled depersonalization syndrome. And I think to put a face on that word, I could tell you about Shelley. Shelley was in her late 20s, and I had known Shelley off and on since she was about 14 by the time this happened. And Shelley had been in and out of the practice. She hadn't been one of the easiest teenagers to bring up. Mom and Dad live around the corner from us, and they had struggled with her, and she'd been one of those troublesome kids. I've got one too, so I sort of know what she went through. And a little bit of acting out and everything else like that. Went off to college, got a college degree, got into a relationship and had a baby, and was living back in town. At that point, she was living on her own with her baby, but seeing her mom and dad quite frequently. And so she was back in our practice. And I had seen her on a number of times and done just routine care for her. And then one evening, I got called in to emerge. And they said, this patient is being really difficult. Come in and see her. So I went in to see her, and I wasn't pleased about him being there. So I wasn't the patient wonderful doc that I got the award for being when I got to see her. She had been persistent in her sort of self-destructive behavior, and this was the last straw. She'd taken a whole ton of alcohol, take a whole bunch of pills, and slashed her wrist, and she was lying there in emerge with a suicide attempt, because actually there was no risk to her life at that point. And as soon as I walked in the room, she put on the poor me drama queen bit. And at that point, I just sort of lost it a little bit, and I said, Shelley, give me one reason why you hate yourself so much that you would do this to yourself. And she looked at me, and she said to me, I don't know. And she started to cry, and she said, I don't know who I am. And I went, okay, yeah. She said, ever since the abortion that I had when I was a teenager, even when I look in the mirror, I don't know who I'm looking at. And that was the first time I'd actually had a woman actually be able to use words to describe her feelings of depersonalization. And she had, after her abortion, cut herself off from who she was, such that when she looked in the mirror, she really didn't recognize herself. When she thought about herself, she thought about herself in terms of being a stranger. And so she couldn't get in touch with her feelings, and she couldn't grieve. She couldn't deal with her guilt. She couldn't deal with her anxieties. She couldn't deal with her feelings of inadequacy as a mother. So I was sort of a little bit flabbergasted, and I just sort of stood there and said, what abortion? Because she'd never told anybody that she'd had an abortion. She hadn't told her mom, she hadn't told her best friend, she hadn't told her boyfriend, she hadn't told her husband, and she'd never told her physician. So that started a long process of counseling and work. And Shelley is now married. She's working full time. She's got another little one. She's got a very happy family household. It took her about 5 years of counseling to be able to work through the issue she has. And as she said, find herself, because that's what she really had to do. Do we talk about this? Do we talk about excessive alcohol abuse, which is shown? Six-fold increase in alcohol abuse, 6-fold increase in the use of drugs, 6 times the increase in successful suicides. That's girls not like Shelley, who just made the attempt. That's girls who are so desperate and so alone and so sad that they kill themselves. And most of these girls are under the age of 25. We in Canada are facing an epidemic of suicide in our young people. But we don't look for a cause. And we don't inform people about what the causes might be. And we don't talk about it because it's not politically correct to blame abortion for anything. Can I validate what I'm telling you? Sure I can. All there's studies, and there's great studies out there. One of them is the Stake study. It was done over in Europe. Again, I tell you, their demographic information and their medical information is great. And they were the ones who came up with the 6-time increase in the rate of suicide. An enterprising fellow did a study in Wales. Again, they do a lot of collecting information. He found a 225% increase in suicide rates, the successful completion of suicide rates. He also found the same sort of rate of suicidal ideation. And what was very, very disturbing for him, because he did a long-term study, he followed these girls for 12 years. And he found that this suicidal ideation, which was present after they were born, after they had their abortion, persisted. And it didn't wane year after year after year. It was a persistent problem. Probably because they don't get adequate care. Probably because they don't access mental health services. But the most pivotal study was the one which was published in 2005, and it was by a guy called Ferguson, and he was down in New Zealand. And he will tell you in his paper, he's a psychiatrist, and he's actually at their medical school, and he's very frank in his introduction to a study. He said, I did this study to debunk the myth that induced abortions lead to increased mental illness. That's why he did the study. So he did a 25-year case-controlled longitudinal study, double-blinded, in New Zealand. What he did is he just had all the girls enrolled, and he enrolled them subsequently at the age of 12 and 13 when they entered into their middle school program. And then they followed them. And every time those girls accessed medical care for a sore throat or for a needle or for an abortion or for depression, they got cataloged in their list of stats. So they knew exactly what the premorbid condition of these girls were in terms of their mental status before they had their induced abortions. And they could compare that to what happened after their induced abortions. They found no correlation with the girls who were difficult, who were having behavioral problems at school, had an increased rate of mental health problems afterwards. They did find that the girls who had psychiatric symptoms, once they went through an abortion, they got worse. So one of the things which they established very clearly is if you take somebody with a defined mental illness and they have an induced abortion, they get worse. When we had our abortion boards, like before 1988, the most common reason for a woman to get an induced abortion was for mental health reasons. And I have just finished telling you that the studies have shown that to treat mental health problems with an induced abortion only makes them worse. My book, that's called Bad Medicine. The other thing which he found, to his great surprise, that there was a statistically significant increase in the rate of mental illness in girls who'd had induced abortions. And those were the statistics that I was creating earlier. Carly wasn't told any of this. It was just last week, Carly's mom was in again. And she said, you know, Carly's still not right. She's irritable, she's upset, she's off to college now. She comes home every weekend. She's really not making the progress that we thought she would. I wonder whether if Carly knew that she would suffer this much following her abortion, whether she would have ever had it in the first place. And you know, that's a very valid question, but we don't have the answer to it. And the answer lies in the fact that Carly didn't really make a choice to have an abortion. She decided to go to the abortion clinic to have an abortion, but she didn't make an informed decision because nobody gave her the information on which she could make an informed decision. Instead, somebody took over in a paternalistic way and said, don't worry, dear, everything's going to be all right. Just sign the paper. What we know about informed decision is that not only does it increase compliance, as I said before, but people can accept the outcome, negative outcomes, of an intervention if they had an informed decision to start off with. If they bought into the procedure before they started, then they can accept what happens afterwards. And they can deal with it. And they can work on it. But if they weren't part of the decision making and they had abdicated that decision making to somebody else, they have a real hard time even starting to understand it. And this is because their personal autonomy was not respected. And because the decision didn't belong to them. And the basics, the underlying ethical principles on which an informed decision or informed consent lie on is that principle of personal autonomy. And also the principle that we need to respect one another. We need to respect one another, and we need to respect the dignity in one another. And I'm not talking religious language. I'm talking the language of ethics, and I'm talking the language of our legal system. And they tell doctors that an informed consent means that we recognize personal autonomy and that we respect a person for their own dignity. And in so doing, we reveal to them all material risks. Those are risks which could have a significant impact on their life, either because they're going to last for a long period of time or they're going to really affect them in some way or another. What we're doing when we don't offer a patient-informed consent, when we don't tell people about what's going to happen afterwards, when we don't recognize their ability to make their own decisions, when we don't give them the time to think about it, when we don't give them the opportunity to ask questions and don't respect them enough to give them real answers, is that the physician is practicing negligence. And if you're caught at it, it can cost you your license. The thing is do you think any of these girls report this negligence to the college? No? You know why? Because they didn't even know that they had a right to an informed consent. We are called, as citizens, to say this needs to change because we need to protect our young people. So our obligation, grounded in ethical principles, has to be enshrined somehow in our legal system, has to be enshrined somehow in our medical system, and it is. It's called this Health Care Consent Act, which was passed in 1996, which says that doctors and anybody who provides medical services for people are supposed to have informed consent. We just don't do it. The Royal College of Gynecologists and Obstetricians in England, on their webpage, state that induced abortions increase your risk of mental illness and premature deliveries. They do not talk about the increased risk of breast cancer, which I didn't talk about either, but that's there too. Actually, Joel Bryn did a meta-analysis on the studies which were done on breast cancer. There were 33 done. He selected out of that the ones which he could get the original data from, and he did a logarithmic regressional analysis on that data, and he found without a doubt that there's a statistical increase in breast cancer from having a single induced abortion, okay? And how big is that risk? It's about 30%, so it increases your relative risk rate by about 0.3. Doesn't sound like very much, but it's exactly the same amount that taking hormone replacement therapy when you become menopausal increases your risk of breast cancer. And how many of you know about that HRT scare a couple of years ago, and all the doctors whipped everybody off their HRT because it was going to give them breast cancer? Induced abortions cause the same risk. So we don't talk about that. There's a conspiracy of silence. Nowhere in any of the official documentations in Canada, in the Canada Health documents on abortions, they have a big, huge bulletin on maternal fetal well-being and infant mortality. Nowhere is induced abortion mentioned. Nowhere. The American Association of Obstetricians and Gynecologists, it's in their appendix on page 475. Induced abortion is an immutable risk for the development of both premature deliveries and increased mental health problems. It's there. It's not even there in Canada. We really need education. We need a little bit of lobbying, but we need more studies. And one of the most critical things we need is a Canadian study, We need the same sort of study that Ferguson did down in New Zealand and that the EpiPage people did over in Europe and the Europop people did. We need to take a look using those OHIP card numbers and doctors' billing practices and doctors' billing rights. It'd be totally confidential because people would only be identified by their number. And we need to get the same we need to look at concordance between induced abortion and prematurity, breast cancer, and mental health here in Canada. And once we have that study, we can say, this is Canadian data, this is significant, this is what we need to do. And we would like to do that study. We need help, and we need money. So, I'm really glad you're all here tonight. You've listened to my talk, and now you've listened to my plug, so that you'll actually talk to other people about this, and maybe somebody will be inspired to give us the money that we need to do the study. Maybe somebody with the time, skill in doing studies will come forward and say, I'd be really interested in helping you with that. Because that's what we need. That's what the women of Canada need. Thank you very much.
Into a newborn day. Oh, flaming with all the glow of sunrise of beams when it's calling, the vow that all betray. For the passions that thrill love and lift you high to heaven are the passions that kill love and let you fall to